So, hello everyone. Today we will have a great Scleritis session with world experts. We have Dr. Peter McCloskey as a thematic lecturer who will start our program. Then we will continue with the presentation of clinical cases by fellows of Dr. Sibel Kadayivsila and Dr. Christian Ursua. So welcome everybody, and please, Dr. McCloskey, you can start.
Good morning, good afternoon, good evening, wherever you are. I'm in Sydney and it's quite cold and extremely wet. And also I just want a disclaimer. There's been a fantastic solar storm the last couple of days, and the sort of viewing the southern lights, the southern hemisphere equivalent of the northern lights, are probably the best conditions for about the last 30 years. This slide down here on the image on the bottom right of my screen is from one of my friends in Hobart, and he can see these images in downtown built up Hobart. But the reason for telling you about this is sometimes it makes the internet extremely unstable. So if Alex, my fellow, or I disappear, it's the Southern Lights that have done it. So I've been asked to talk and give an overview lecture about scleritis. And the way I usually approach this is to try and give you a scleritis survival guide, because there are really 5 key messages that I think it's important that all of us know about scleritis. First of all, it's rare, but it's very important. It's very commonly associated with systemic diseases. The more severe the scleritis, the higher the risk of having an associated systemic disease. We've always got to worry about an infectious cause for scleritis, and we pretty much always need some form of systemic therapy. There are exceptions, but essentially you need systemic immunosuppressive therapy of one form or another to treat it. And my talk will just go through and reinforce these 5 messages. So I want to start with Peter Watson's classification of scleritis, which is 48 years old this year and has really stood the test of time. It's a straightforward anatomical classification, anterior or posterior scleritis. Obviously, you can have panscleritis as well. And you can grade the infection as either non-necrotizing or necrotizing. Non-necrotizing has diffuse and nodular forms in the anterior or posterior segment, and you can see necrotizing scleritis involving either the posterior or anterior segment. And there's this other form, scleromalacia perforans, that I'll also talk about. Excuse me. So the key thing about scleritis, one of Mr. Watson's favorite sayings was that if you didn't think of the diagnosis of scleritis when you were taking the history, you are unlikely to make the diagnosis, because it's the history that really gives you the clues that you need. You can have a red eye, a tender eye, the vision can be a little blurry, but it's the pain that is the hallmark clinical symptom. And this is pain that comes on over days to weeks. It's dull and aching, it's retrobulbar, it radiates across the sort of innervation of the 5th nerves up to the forehead, the scalp, to the ear, to the lower face, to the jaw. It's dull and aching. It's often the worst pain the patient has ever had. It classically gets worse at night, wakes people from their sleep, usually early in the morning. It's typically fairly poorly responsive to conventional analgesics. And depending on exactly how the patient presents, they may have seen a number of other doctors, been investigated for a whole range of different causes of facial pain and headache. The other really important feature are the signs. So that you can have a red eye, you can have an injected globe that's tender. There's definitely scleral edema, and there's very typical and important changes in the episcleral vasculature. You can have nodules, necrosis of the sclera, and corneal involvement. The hallmark sign is involvement of the sclera. And what happens is that the sclera becomes swollen and edematous, and the overlying vascular plexus has become dilated. And if there's necrotizing scleritis, they close off. And it really requires a careful clinical examination with the slit lamp to detect that not only the conjunctival, the most superficial plexus, is dilated and engorged, but the deeper deep episcleral vascular plexus is also dilated and pushed out by the scleral edema. The middle vascular plexus, the superficial episcleral plexus, is pushed out because there is edema of the episcleral and subtenons tissue. But it's that deepest layer of vessels that you need to look at, and they have a sort of a crisscrossing pattern. And once you've sort of seen it and get the impression that they're just been sort of pushed outwards, it really becomes a useful sign. Often a red-free light, the green light on the slit lamp, makes the vessels stand out more easily. Recently, we have now swept source OCT that can actually detect the scleral edema, but they're not sort of routinely available at this time. But I think over the next 5 to 10 years, OCTs of the anterior segment are really going to change how we can diagnose and how we can prognosticate about the severity of scleritis. As I said earlier, there's diffuse, nodular, and necrotizing anterior scleritis. And as you go from diffuse to necrotizing, it's a more severe form of the disease. Necrotizing is a serious threat to the integrity of the globe. It can be subtle or it can be obvious, as you can see in the case here. Diffuse is by far the commonest, and necrotizing is the least frequent, but as I say, the most severe. Also, very commonly, you can get involvement of the cornea and the limbus. And another one of Mr. Watson's contributions was that when you have scleritis that crosses the limbus into the cornea, that's a sign that often means there's an associated systemic disease, typically rheumatoid or ANCA-associated vasculitis. You can see a whole range of different types of keratitis in patients with scleritis. It typically occurs in severe necrotizing scleritis, but you can see it really with any form. And it can be localized. It can be just a sort of a stromal opacity, what is often called floss candy keratitis. There can be lipid deposition. There can be areas of just limbal ischemia that damage the cornea. There can be quite obvious peripheral ulcerative keratitis. And you can also get central corneal melts, which often occur in an otherwise looking relatively uninflamed eye, but an important sign and a classic sort of manifestation of vasculitic rheumatoid arthritis. The equivalent signs in the posterior sclera are harder to see clinically, and that's where sort of B-scan ultrasound is really useful. Again, you can see diffuse involvement of the posterior sclera. You can see nodular involvement of the posterior sclera. Necrotizing scleritis we can't make at this time with multimodal imaging, so you need to see that obviously operatively, and the classic time where we see this is in patients who've got infective posterior scleritis around a scleral buckle, and you sort of explore that and can see clear evidence of necrotizing disease. You can also, of course, pick it up pathologically. The other important ultrasound sign is the T sign from fluid in Tenon's capsule and distension of the optic nerve sheath from involvement by posterior scleritis. Posterior scleritis has a range of signs that I'll go through. Similarly to anterior scleritis, recurrences occur. It's commonly associated with systemic disease and a much more serious threat to vision because of the structures like the retina, macula, optic disc that can be involved. The way I like to think of the clinical features of posterior scleritis is that either involve the posterior pole, where you can have changes such as a subretinal mass. You can have a swollen disc and retinal folds and lipid involving the macula. Sorry, you can have choroidal folds from more diffuse involvement of the posterior sclera. You can have a serous retinal detachment, which you can obviously see and identify very well on OCT scanning. If the posterior scleritis involves the more peripheral posterior sclera, the classic sign are choroidal effusions. You can also get overlying serous retinal detachments. If those choroidal effusions come forward and involve the ciliary body, you can get secondary, rotation of the ciliary body and secondary angle closure and a very high intraocular pressure. So occasionally these patients present with angle closure glaucoma. The thing to look for is whether the central anterior chamber is shallow. In primary angle closure, that tends to remain deep or deeper with a very shallow peripheral anterior chamber shallowness. Whereas when it's secondary angle closure, the whole anterior chamber is very, very shallow. One of the commonest times that we see posterior scleritis is involved with anterior scleritis. So it can either be that you have a large nodule of anterior scleritis and involvement further back, or as in this upper image where there's posterior scleritis coming forward to where it's easily visible. Uncommonly, we'll just see patients with a red, painful, tender eye and reduced vision and really not much else. These patients typically have B-scan ultrasound abnormalities, but not much in the way of other signs. So scleromalacia perforans is a very carefully sort of defined entity. A lot of non-ophthalmologists sort of say that someone has scleromalacia when they have scleral thinning or loss of scleral substance from any form of scleritis. But the original definition by Peter Watson was basically that it's an endarteritis obliterans that's asymptomatic, and it presents with blurred vision from astigmatism from loss of scleral tissue. And basically what happens is that areas of the sclera become infarcted. You get sequestra that then get reabsorbed, and you get these blue areas of very, very thin sclera and parchment white areas where the sclera is dead and then going to become reabsorbed. It's very rare now in the developed world because it's basically only seen in patients with rheumatoid arthritis associated vasculitis, which is now very uncommon because of the much better treatments and the much more aggressive earlier treatment. So patients with severe deforming rheumatoid arthritis are the group where we used to see this. Now, like most things in scleritis, its frequency is different in different parts of the world. Another important sort of subset of necrotizing scleritis is surgically induced necrotizing scleritis. Back when we used to do extracapsular cataract surgery, it was more common than it is now with clear corneal phaco. This is an old patient of mine. It's hard to see, but it's an old extracap wound. There are still some tenonylon sutures there. The necrotizing scleritis is usually severe. It always involves the wound. So if it's a cataract operation, it involves the cataract incision. If it's from strabismus surgery, it'll be where the muscles have been resutured to the globe. It usually presents within 6 months of the surgery, but it can be long delayed. It's very commonly associated with the systemic autoimmune disease. Importantly now, it's usually infective and not inflammatory. So it's not surgically induced necrotizing scleritis, but it's now typically infective scleritis. And certainly in my part of the world, the classic patient where we see this is someone who's had pterygium surgery, particularly someone who's had mitomycin C to try and prevent a recurrence. And these patients, it's usually either Pseudomonas or a bad sort of mold fungus like Scutosporium or Fusarium, and a very difficult disease to treat. It can occur obviously after pretty much any form of eye surgery that where the sclera is exposed. We can also see it obviously after trauma. We can also see this associated with systemic infections like TB and syphilis. It's a classic complication of herpes zoster ophthalmicus. You can get infective scleritis from contiguous spread of a corneal infection, herpes simplex keratitis or acanthamoeba. And very occasionally, if you've got very severe intraocular inflammation with, say, herpetic retinitis or severe toxoplasmosis, you can get sort of extension superficially to involve the sclera and either get diffuse or nodular scleritis overlying the intraocular inflammation. As I said earlier, scleritis is commonly associated with systemic disease. Rheumatoid arthritis is still the commonest association, but increasingly the group that we see presenting to us as ophthalmologists are patients with ANCA-associated vasculitis, typically GPA, granulomatosis with polyangiitis, what used to be called Wegener's granulomatosis, microscopic polyangiitis, or eosinophilic polyangiitis, what used to be called Sjögren-Strauss syndrome. We can also see scleritis with a whole range of systemic vasculitides, with seronegative arthritis, with spondyloarthritis, with relapsing polychondritis, inflammatory bowel disease, sarcoidosis, gout, IgA nephropathy. So a very broad range of important diseases. There's been some nice work that's identified risk factors for scleritis being associated with systemic disease. As I mentioned earlier, as you go from diffuse to necrotizing, so increasing severity, the older the age of the patient onset, the more likely it is to be associated with systemic disease. As I mentioned earlier, corneal involvement. We'll get onto this in a moment, but symptoms that would suggest that the patient could have an associated disease, and also having positive ANCA serology is a big clue that you might have a systemic disease. So the pathology of scleritis is not well understood because it's hard to get specimens, but some work that my group did, 25 years ago or more now, where we got biopsy specimens from patients with scleritis and added to the knowledge that's already there that it's an immune complex vasculitis surrounded by granulomatous inflammation. Importantly, it's a B cell dominant sort of infiltrate of inflammatory cells. There's a lot of pro-inflammatory cytokines. It's the usual suspects, TNF alpha, IL-6, interferon gamma that drive the inflammatory reaction. And the work that we did identified that the collagenolisis that Peter Watson and others noticed back in the 70s and 80s is due to activation of matrix metalloproteinases and a dysregulation between the matrix metalloproteinase secretion and the tissue inhibitors of metalloproteinases, so that you get overexpression of the MMPs, and that's what leads to the collagenolisis and destruction of the matrix of the sclera. Excuse me. Another very important but long-standing observation is that necrotizing scleritis is a bad disease. This paper from Steve Foster's group back in the 80s showed that without aggressive systemic immunosuppression, necrotizing scleritis had a 50% 5-year mortality rate. And we still see the effects of this sort of outcome in patients who aren't with bad disease, that aren't treated aggressively. Classically, people with ANCA-associated vasculitis is probably the commonest group that presents to ophthalmologists. So how do we diagnose this disease? Like most things in uveitis and many things in medicine, it's all about the clinical assessment. So it's the history, the examination, making sure you do a directed systems review, thinking about the likely associated diseases, obviously arthritis for rheumatoid, spondyloarthritis, things like that. For ANCA-associated vasculitis, airways type symptoms, relapsing polychondritis, ear and nasal symptoms. respiratory symptoms for a range of the diseases that we see, ANCA-associated vasculitis, again, relapsing polychondritis, and so it goes on. But it's really the aim of the process is to make the diagnosis initially, see if you can recognize a syndrome, or at least come up with a sensible differential diagnosis, and then we'll do some selective investigations to try and rule in or rule out these diseases. Now, there are lots of different things that you can do, but this is basically the sort of baseline set of investigations that I do in pretty much every patient. A chest X-ray for sarcoid and cavitating type chest lesions and other lesions, autoantibodies, particularly ANCA serology, ANA, rheumatoid factor and anti-CCP. In other patients, we'll look at things like renal function, urine analysis. We always check the syphilis serology. If I'm worried it could be polyarteritis nodosa, we'll do hepatitis serology. Imaging studies are obviously very useful. A quantiferon gold is important if you're practicing in a TB endemic region of the world, or if you're, regardless of where you are, if you're going to immunosuppress the patient. Sorry. The other important thing is we not uncommonly need to consult other colleagues, and it's really critically important to highlight just how essential careful clinical assessment is. Doing the tests without a good examination really won't help you make the diagnosis. If we turn now to treatment, it's really, there's no sort of good specific literature evidence for how we should manage these patients. Because it's a rare disease, there's really no RCTs that can help us to guide our management. So it's mostly based on case series and expert panels like this one from back in 2000. We basically use stepped systemic therapy based on the severity of the scleritis. I'll talk a little bit about biologics and where they fit in, and subconjunctival triamcinolone. But obviously, the treatment that we want to use may really be have to be modified depending on the associated systemic disease. And the treatment for that may well be more than sufficient for the scleritis. So as I've said, our treatment is proportional to the severity of the disease. Often with diffuse and nodular scleritis, we can get by with either an NZ orally or prednisolone. Because necrotizing scleritis and posterior scleritis are a much more severe threat to vision, usually they'll need combination immunosuppressive therapy. As I say, if there is an associated systemic disease, they usually will need systemic immunosuppressive therapy. And some of our patients with infectious scleritis also need systemic immunosuppressive therapy. This is a treatment algorithm that I've modified from this 2017 paper, which really is quite a nice way of thinking about the treatment. So if you have anterior non-necrotizing disease, you can either use an oral NZ or prednisolone. In selected cases, we can use subconjunctival triamcinolone. A small number of our patients will need a steroid-sparing agent because they'll need treatment for 6 to 12 months or more to keep their scleritis suppressed. Rarely do we need biologics for anterior non-necrotizing scleritis. Posterior necrotizing scleritis pretty much always needs combination immunosuppressive therapy. So we'll get the disease under control acutely with steroids, add in a second agent, a steroid-sparing agent, and these days, if it relapses, we'll go fairly quickly escalate to a biologic. Obviously, these are non-infectious scleritis patients. Necrotizing scleritis, as I keep harping on, is a bad disease. We need to treat it aggressively with oral steroids. Sometimes we'll use IV methylpred, but you've got to be sure you've eliminated infection. We'll usually start with either methotrexate or mycophenolate as their sort of first-line steroid-sparing agent. And if we're not doing well with these, then we'll escalate to either a TNF blocker or a B-cell depleter, because these biologics Matt, that fits in nicely with what we understand about the pathology. If you've got bad scleritis and it's hard to access a biologic, cyclophosphamide is probably the best drug that we've got. It works very well for severe sort of vasculitic inflammation. For sort of relatively short courses, it is safe and it's extremely effective. You can use it as either pulsed IV doses on a monthly basis or orally, and it's a very useful drug. Excuse me. The subconjunctival triamcinolone is a very useful therapy. The most important thing is you've got to make sure that it's not infective scleritis. And given that TB is very common in many parts of the world, we have to be sure that it couldn't be tubercular scleritis. That's a problem in regions of the world where TB is endemic, but important to get that message across. I tend to use subconjunctival steroids either in patients with non-necrotizing disease. It's very useful in patients who are having side effects from steroids or have got contraindications to oral steroids. It is really a relatively straightforward treatment to do. It's important to make sure that you put the injections of the triamcinolone out in the fornix, away from the limbus. It's different to the way you might give subconjunctival steroids for someone with severe acute anterior uveitis. I like to use triamcinolone 40 milligrams per mil, and we use 0.05 of a mil, and I'll put 1 to 4 little injections in the fornices of the quadrants that are involved. Back in the 70s and 80s, this was thought to be terrible treatment for scleritis and totally contraindicated because they had a number of patients who got terrible scleral melts and lost their eyes. That is still a risk, but because we're much better at sort of sorting out scleritis and identifying patients where it's safe to use these non-infective, non-necrotizing anterior scleritis, the risk of a scleral melt is very low. It's probably somewhere between 0.5 and 1%, but it's not zero. So it's important that the patient understands that. Infectious scleritis is a bad disease. And certainly in my unit, in my hospital, we like to manage these patients, or co-manage them, I should say, with our infectious diseases colleagues. I don't have much experience at all with TB-related scleritis because I don't practice in a TB endemic area, but obviously TB scleritis needs ATT, like other forms of ocular TB, and you will almost certainly need some local, some steroid therapy as well. Herpetic scleritis needs combination with intravenous or oral antivirals, and they will often need some form of anti-inflammatory therapy as well. This is the sort of horrible herpes zoster ophthalmicus that we're hoping to minimize through vaccination, which I'll talk about in a moment, and early use of antiviral drugs. Acanthamoeba scleritis is a horrible disease and very, very difficult to treat. And my experiences of that disease have been fairly bad, terrible outcomes. But as I say, with infection, you often need judicious systemic therapy as well as the antimicrobial therapy. I think the big thing that's changed in infectious scleritis is now we've actually got a zoster vaccination that works. This new vaccine, Shingrix, is very, very good. You need 2 doses. It's expensive if you can't get it through your health system. It's not a live vaccine, so we can use it in the patients that we're most worried about. So patients who are immunocompromised or HIV infected patients. If you're not immunocompromised, they advise 6 months between the 2 vaccinations that you need, but you can telescope that down to 2 months if you've got someone who's immunocompromised. Sorry, this is a local This is Aboriginal and Torres Strait Islanders. These are our Indigenous Australians, where shingles can be quite a problem. So our health system lets you access that earlier for our Indigenous Australians than for other Australians. So occasionally, for very, very severe infectious scleritis, we've used these subpalpebral infusions of antibiotics. This is actually an epidural cannula because epidural cannulas are blocked at the end and have a series of fenestrations along there. And you can just put it through the upper eyelid into the upper fornix, connect this up to an IVAC pump with your favorite antibiotic, and just marinate the sclera in antibiotic or antifungal medication. And after you've debrided it and opened up the sclera, we've saved several eyes that we thought we were going to lose by doing this therapy. So that's pretty much what I wanted to cover. So if we go back to our key messages, it is a rare disease, but we can classify it, we can work out how severe it is. The classification system has worked for 50 years. Clinical assessment is the key step in making the diagnosis. It's important because up to 50%, it varies around the world from anywhere from 10 to 50%, depending on the type of clinical practice that you have in the community where you work. The more severe the scleritis, the more likely it is to have a systemic disease associated with it. Necrotizing scleritis is a bad disease, both for the eye and for the patient generally. We must always think about infection and try and either rule that in or rule that out as a diagnosis. And the treatment virtually always requires a sort of systemic immunosuppressive therapy of one form or another. So thank you very much. I hope I didn't go over. This is what Sydney should look like, but sadly at the moment it doesn't. So thanks very much, Alejandra and Rima. I will stop sharing my screen.
Thanks so much for the fantastic talk, Peter. We now continue presenting clinical cases by Dr. Figen Becci and the discussant, Dr. Sibel Kadayev-Sila from Turkey, who will present infectious scleritis. If you have questions, please leave them in the Q&A session and they will be answered. Peter, there are already questions for you. I would appreciate if you could answer them. Thank you so much. So, Dr. Figen?
Okay, hello.
Hi.
Good afternoon, everyone from Turkey. I will share my presentation. First, I want to express my gratitude for this opportunity. Today, I will present an interesting infectious scleritis case. We had a 64-year-old male patient who presented with severe pain and redness in his left eye as shift complaint. His history revealed that pain and redness in his left eye started 3 weeks after retinal detachment surgery. Despite topical antibiotics and corticosteroid drops, the symptoms did not improve, and subsequently, patient developed upper eyelid swelling and tearing. We learned that he had coronary artery disease, hypothyroidism, and hypertension from his past medical history. Further investigation into the patient's history revealed that he underwent scleral buckling surgery for macula of rhegmatogenous retinal detachments with cryotherapy and C3F8 gas 1 month ago at our center. His preoperative visual acuity was counting finger from 1 meter. As you can see in the OCT scan, macula was off preoperatively. After surgery, post-operative first week, although there was still subretinal fluid, the retina was attached, and his visual acuity improved to 0.4. But post-operative second week, patient had new onset pain. The retina remained attached, but we detected scleral hyperemia at the upper temporal region. Also, his visual acuity decreased to 0.3. We prescribed oral non-steroid anti-inflammatory drugs, and a checkup was recommended 2 days later. But he came back with severe pain after 6 days. At initial presentation, the routine ophthalmological examination was normal for in the right eye. Visual acuity decreased again 0.1 in the left eye. We detected swelling of eyelids and also temporal conjunctival injection. His scleral examination showed that there was prominent redness and tenderness in the upper temporal region. And also there was visible radial exoplant and circumferential buckle on the surface of sclera underneath the tenos capsule. Fundus examination disclosed that retina was attached with cryotherapy scar and effective scleral buckle and radial exoplant in the temporal periphery. There was gas bubble located superiorly. And OCT showed that decreased subretinal fluid, especially under the fovea. At initial presentation, he was using ciprofloxacin and dexamethasone drop 4 times a day, and tropicamide drop 1 times a day. Also indomethacin 25 milligram 2 times a day. Based on all these findings and patient's clinical presentation, we decided infectious scleritis as a preliminary diagnosis. Immediately, we performed conjunctival swab, smear, and culture. He was hospitalized and consulted to infectious disease department. After receiving conjunctival smear test as gram-positive cocci, we initiated IV sulbactam ampicillin as empirical treatment. The next day, there was no resolution or regression of these symptoms. He had still redness, pain, and also increased purulent discharge. 2 days later, conjunctival swab culture resulted as medicine-resistant Staphylococcus aureus. And antibiotic susceptibility tests revealed that MRSA resistant to ampicillin, cefoxitin, gentamicin, and ciprofloxacin, but sensitive to linezolid, teicoplanin, and vancomycin. After these results, we stopped ampicillin sulbactam and moxifloxacin drop and initiate IV vancomycin and fortified drop every 2 hours for a day. 10 days later, under this treatment, there was significant improvement in his symptoms. Following a 10-day course of intravenous therapy, the patient was discharged with oral antibiotics. 2 months later, regression was more prominent. We did not require any additional interventions due to his good response to treatment. And also his visual acuity improved to 0.4. Long-term follow-up, 1 year later, the conjunctiva and sclera was quiet and white. We can easily detect scleral buckle and radial exoplant. There was complete resolution, and his visual acuity improved to 0.5. And his retinal examination showed that although there was a minimal subretinal fluid under fovea, retina was attached. Thanks for your attention.
Thank you. That was an excellent case.
Thank you.
Wonderful. So we'll have questions and answers at the end of the cases. So with this, we now move on to the second case, which is a necrotizing scleritis case, which will be presented by Marcelo Vega.
Shall I present my discussion?
But the discussant is Dr. Sibel for
Okay.
this case. So before the other case. So please,
Okay.
Dr. Sibel, go ahead.
Okay, I'm going ahead and with the discussion. And first of all, thank you so much for involving us in this grand rounds. We send our regards from Ankara, Turkey. As Peter has already said, infectious scleritis comprises nearly 10% of all scleritis cases in Western world. However, there are increased incidence reports from India, and they may be exogenous due to post-traumatic or post-surgical cases like in our case, or endogenous, which are less frequent, and they may be associated with systemic infections like syphilis and tuberculosis. And there are some predisposing factors, and one of them is ocular trauma, and the other is recent ocular surgery. It's generally seen after pterygium surgery, which is more facilitated with the use of mitomycin C or local radiotherapy. And also chronic use of topical corticosteroids are also a risk factor. In our case, there was pain, which we see after initial healing. If there's a persistence of pain after surgery, not improving despite topical or systemic anti-inflammatory therapy, we have to rule out infectious scleritis or surgically induced necrotizing scleritis. When we look at epidemiology and visual findings, visual outcomes in patients with infectious scleritis, let's look at this report from Miami. From here, the inciting event to scleritis symptoms were nearly about 2 months later, and the most commonly isolated microorganism was Pseudomonas aeruginosa in this series. Our case may be considered as a scleral buccal infection, and which is seen in nearly up to 6% of cases after retinal detachment surgery, but the time to onset of explant infection is nearly 2 to 8 months, reported more later. And the patients have chronic irritation and discomfort rather than severe pain. And we see mostly erosion of the conjunctiva up on the upper side of the implant, and we see purulent discharge, but sometimes patients are not even aware of this infection. And mostly staph species, Pseudomonas, and non-tuberculous mycobacteria, and also fungi are identified in such cases. They were mostly seen with sponge type of exoplants. Nowadays, we use mostly solid silicone implants as they are economical, easy to obtain. They are soft, inert, non-allergic, and generally well tolerated. But when implanted, they may compromise local tissue and result in necrosis and inflammation. Saprophytic or low virulence organisms like Mycobacteria species may adhere to implants and form an extensive biofilm. This biofilm results in protection of that microorganisms from high concentrations of antibiotics and the attack of cellular defense of the host, so this may result in persistence. Let's go to India again and see what they found in scleral buccal infections. They found mostly gram-positive cocci and mostly Staphylococcus epidermidis. A more recent report from Yan considering scleral buckling surgery and infection, the incidence was only 2 in 1,000, so a less decreasing incidence. And mostly Staphylococcus epidermidis was isolated again, and the mean interval was 30 days after the implantation. And in most of the cases, there was scleral or buccal or suture exposure, like 80%. However, in 18%, there was no scleral, explant erosion, no conjunctival erosion around the explant or suture show, which was similar to our case. Our conjunctiva was totally closed in this infection. I looked at methicillin-resistant methicillin-resistant Staphylococcus aureus infectious scleritis at PubMed. I can only find 5 reports. One of them is after dengue viral fever. Here, the patient had infectious scleritis, which didn't improve with oral therapy. When teicoplanin was given, the patient improved even after the first IV injection. And as Peter has already taught, surgically induced necrotizing scleritis has to be ruled out, but we can only rule out it after the infective etiology can be ruled out. It's a clinical diagnosis, which has components of trauma, infection, ischemia, toxicity, and autoimmunity. It can be seen after infectious scleritis, or infection can be seen superimposed to surgically induced necrotizing scleritis. What's the treatment? We generally see culture positivity in nearly 80% of the removed implants, and most are gram-positive cocci. And gram-positive cocci and gram-negative bacilli are mostly sensitive to ciprofloxacin. So it may be given while awaiting the culture and antibiotic sensitivity reports. Our case was already taking ciprofloxacin drops. However, our culture results showed methicillin-resistant Staphylococcus aureus. Therefore, we changed our treatment according to the culture and sensitivity results and get a good response. And it's important not to give steroids in the acute phase in those cases. So what about removal of the buccal? Shall we remove it or not? Our case presented on only at the third week after the surgery. So, and there was still subretinal fluid. Therefore, we elected to go first with the infection control and then decide about removal or not. But we got a good response, and after 2 months, everything was okay. So we elected not to remove the buccal because removal causes up to 80% of redetachment. However, in the case, in the report from India, all the buccals were explanted, but not in the immediate period, and only they have observed 2 recurrences of the retinal detachment. So we can wait according and decide according to the response of the patient. There's a good review in the literature, in the recent literature, differentiating between infectious and non-infectious entities. I can recommend this article to you as well. Thank you so much for attending.
Thank you, Figen and Sibel, for the excellent presentations. We will continue presenting necrotizing scleritis with Marcelo Vega presenting the clinical case and Christian Ursua from Chile discussing it.
Thank you very much, doctor. Patient of 55 years old, male, Hispanic, and ambulance driver with medical history of bronchial asthma and testicular cancer surgery in 2008, up to date on vaccinations, has received the 6th dose of COVID vaccine and this year's influenza vaccine. No significant family medical history. The case begins in 2017, characterized by bilateral deep red eye with pain upon palpation and eye movements greater on the right, sensation of orange body, photophobia, tearing, and blepharospasm, without secretions or decreased visual acuity, initially treated as conjunctivitis with topical steroids, showing partial response. Subsequently, there were multiple recurrences of variable durations. In 2019, polyarthralgia, bilateral progressive and asymmetric hearing loss was added, along with tinnitus, erythema of the auricle, vertigo syndrome. The fluctuating nature of the hearing loss was notable, requiring several adjustments of hearing aids. Based on the symptoms described, he was hospitalized for a study in May 2022 due to recurrent episodes of red eye, decreased hearing, vertigo, headaches, and joint pain. He denies symptoms of sinusitis, colds, skin lesions, peripheral neuropathy, or signs suggestive of multiple mononeuritis. In the workup exams, general tests including CBC, LFT, creatinine, and urine examination showed no abnormalities. Non-infectious profiles, ANA, ENA, anti-DNA, ENCA, MPO, ERP3, and RF were negative. In infection profile exams, tests of syphilis and tuberculosis were negative. In the slit lamp biomicroscopy, there was a mild cilioconjunctival hyperemia, clear cornea, no anterior chamber cells or flare, no nodules, central pupil, and clear lens. After a 10% phenylephrine instillation, in primary gaze and upward gaze, the lower sclera appears normal. In infraversion, we can see a scleral discontinuity lesions of 6 millimeters in the right eye and 10 millimeters in the left eye, situated 2 millimeters from the sclerocorneal limbus. Violations in color, well-defined borders covered with normal-looking conjunctiva. With the red-free light, you can see better the blood vessels and areas of capillary non-perfusion. General physical examination revealed auricular chondritis. The audiometry showed moderate bilateral hearing loss with poor discrimination on the left, persistent tinnitus, and healthy eardrums. Definite diagnosis, relapsing polychondritis and bilateral anterior necrotizing scleritis. In the treatment, prednisone 60 milligrams per day, methotrexate 25 milligrams per week orally, and folic acid. Thank you.
Great case. Thank you, Marcelo. And now we have the discussant, Dr. Christian Ursua.
No, yes. So thank you, Marcelo, for this illustrative case of necrotizing scleritis. Well, my name is Christian Ursua. I'm a consultant in uveitis from Chile. We are based in an academic institution in Santiago, the capital city. Now I will discuss some important issues regarding this clinical case. First, I think it's relevant to mention some key points to be considered for ophthalmic examination in patients with scleritis. In that sense, in addition to the routine use of the lamp to evaluate this condition and potential ocular complications such as PUC or anterior uveitis, red-free light and a macroscopic view with daylight may help the clinician to assess the areas of necrosis or non-perfusion, as well as to identify the classical color of the affected sclera in patients with necrotizing scleritis. So first message is, please choose appropriate examination tools. Another important topic is the association of necrotizing scleritis with systemic conditions. In this regard, in this large cohort of patients with scleritis, necrotizing had an increased frequency of associated systemic disorders. Moreover, around 60% of the patients had necrotizing scleritis at the first or initial manifestations of the disease. Indeed, it has been described an increased risk of systemic conditions in necrotizing scleritis, with an odds ratio of 7 times in these patients. And which systemic disorders are more frequent in necrotizing scleritis? Well, according to the scientific papers published at date, RA and GPA are the most reported systemic associations. Therefore, actions should be taken by the clinicians to rule out these two conditions and other disorders according to the systemic evaluation of the patient in particular. Thinning of the sclera is a potential source of complications, and ocular complications are an important issue in patients with necrotizing scleritis. In fact, necrotizing scleritis has the potential risk of this terrible complication, which is glove perforation, in which cases complex surgical procedures are needed. So, how frequent is the presentation of ocular complications in necrotizing scleritis? In this case series from Japan, all subjects with necrotizing scleritis had at least one ocular complication, including cataract, ocular hypertension, and uveitis, among others. In addition, again, in this large cohort, ocular complications were reported more frequently in patients with necrotizing, with a significant difference in decreased vision, anterior uveitis, and PUC. Similarly, decreased vision was found to be more frequent in necrotizing in this multicentric and international study. To conclude, just some considerations regarding the therapeutic approach in necrotizing scleritis. Remember, in our case, methotrexate was started as first-line therapy. Regarding the therapeutic approach, necrotizing tends to be refractory to systemic steroids, and thus IMT is needed. For instance, in this case series, all patients with necrotizing scleritis require IMT initiation to control the scleral inflammation. In addition, the Latores group has described a higher frequency of chronic course of the disease in cases of necrotizing scleritis, which would be an indication for IMT. Finally, some evidence has reported the positive impact of the indication of IMT on mortality. In this case series, authors found a decrease in mortality in patients being treated with IMT, as seen in this graph. So IMT impacts on mortality in NS. In summary, I think the most relevant insights to take home from this case and necrotizing scleritis are: first, please choose appropriate examination techniques. 2, look for systemic conditions in these cases. Consider ocular complications, and please include IMT as first-line treatment. Last but not least, I would like to introduce our group, which is a confluence of clinicians, staff scientists, clinical fellows, postdoctoral fellows, residents, as well as students. Thank you very much.
Thank you so much, Christian and Marcelo. Great presentations and fantastic photos from Chile. And now we will continue with non-infectious scleritis case presented by Alexander Newman and discussed by Dr. Peter McCloskey.
Thanks, everybody. I'll just bring up my screen now. Oops, sorry, just give me a moment. Is that looking okay there, everybody?
Yep.
Perfect, thank you. So thank you for having me. I guess it's evening here in Australia, may not be around the world. Thank you for Professor McCloskey for having me, and I also extend my thanks to Professor Wakefield, who was unable to attend to present the case. So the case begins with a 34-year-old woman who lives in Argentina. She moved to Sydney in early 2023. She was Spanish was her native language, required an English translator. She was otherwise well, no notable ocular disease, and her only medication was an oral contraceptive pill. She was referred to the Sydney Eye Hospital Department of Uveitis in May of 2023 for refractory eye pain and redness. This all began several years ago. She had her initial COVID vaccine, as a lot of people did, in August and September of 2021. 2 weeks following the second dose, her left eye became hyperemic and sore, initially treated with Chlorcig. 3 months later, there was a persistence of symptoms managed with topical steroid. There was thought to be a component of anterior and posterior blepharitis, so doxycycline was trialed. And during this period of time, there was treatment with intermittent use of oral non-steroidal anti-inflammatories, which all had a subtherapeutic effect. She then moved to the United States in 2022, once again, varying doses of topical steroid on and off for 6 months, another trial of doxycycline. You can see evidence here of upper lid edema consistent with hordeola, and these were subsequently treated. And then she had a few months of off treatment as the disease waxed and waned, fluctuating pain and redness in her left eye, and eventually progressed to become bilateral disease. So what you can initially see here on the left eye is now evident in the right eye by November of 2022. She then moved to Australia in 2023 with bilateral red eyes, which had steadily deteriorated over the next 4 months, increasing pain, waking her at night with extreme photosensitivity, almost painful ophthalmoplegia, lid edema, and severe functional impairment impacting her occupation and driving status. She was seen by several ophthalmologists in Australia. Once again, intermittent NSAIDs, blepharitis cares, topical eye drops. April 23, these are a few more of her selfies that she's taken, and you can clearly see the bilateral eye disease. We had a very fantastic patient. This is actually her chart that she provided us with, a spreadsheet of everyone she'd ever seen and everything she'd ever tried. And you can see just an overwhelming preponderance of topical eye drops, topical antibiotics, and oral NSAIDs and oral doxycycline, lid scrubs, but really just really trying to treat ocular surface disease for what is almost 2 to 3 years at this point. And here she is here. Went on presentation with us. She maintained fantastic visual acuity, mild anterior chamber reaction with a healthy cornea, normotensive, clear lens, and normal posterior segment examination. History revealed that she was born and lived in Argentina. I'd been in the States for a year and Australia for about half a year at this point, with an extensive travel history. No previous eye disease, otherwise well, no family history, and only the oral contraceptive pill. Negative systems review, not really giving us any prominent symptoms to latch onto there, with no known TB exposures, no arthropathy, rash, respiratory, GI, or constitutional symptoms, no ENT symptoms. Initial investigations were somewhat unremarkable normal blood count, normal inflammatory markers, normal renal and liver function, negative syphilis serology, normal chest imaging. Incidentally, there was a normal colonoscopy. We did not perform that one. She had additional investigations with us to exclude infection. Quantiferon gold, negative, normal angiotensin converting enzyme, anti-nuclear antibodies, extractable nuclear antibodies, all negative. She was HLA-B27 negative, hepatitis B and C negative, and HIV negative in preparation for depression. Of note that she did have a screening test for ANCA done, which was positive with indirect immunofluorescence. However, antibody testing for myeloperoxidase and proteinase 3 were negative. So to summarize, we have a young, otherwise well lady from Argentina with no previous eye disease, with normal systems review and non-contributory investigations. And we've subsequently diagnosed her with bilateral non-necrotizing anterior scleritis. And of course, a consideration for all young women. She was keen to consider family planning at some point in the future. She was initially commenced on 1 milligram per kilogram of oral prednisone, which had almost completely extinguished her symptoms within 3 days of starting treatment. At her 2-week review, she had completely white, uninflamed, comfortable eyes. Due to her desire for pregnancy, she stayed on monotherapy of steroid with a taper, and we did not investigate further for steroid-sparing agents, whether they were azathioprine or TNF blocker. And she's had a really great outcome, disease-free, off all treatment for approximately 6 months, and to be congratulated on taking such good photo documentation of her own eyes. So, scleritis therapy, take-home messages. I thought I'd throw over to Professor McCluskey just for your comments as well, Professor, if you're around at this point. Just in the context of the presentations we've had today, we can see that this looks like a nodulous a scleritis. You can see the scleral edema, but what made this case so particularly challenging?
Yeah, so I think the challenge was that I guess all of us were a little reluctant to make the diagnosis of scleritis simply because of what it means, systemic therapy, young person, bad diseases potentially that are associated with the disease. So I guess all of us, we try and find, well, let's just trial this local therapy, see if we can settle this down. But in this, as this patient's history illustrates so well, part of the problem was she kept changing positions because she kept moving and changing where she was. So, that old sort of saying that too many cooks spoil the broth, she didn't have the same doctor following what was going on. So it was obviously difficult at a single examination to necessarily make the diagnosis. And we were very lucky. By the time the patient came to us, there was a clear history of pain that was getting worse. It was chronic, relapsing, remitting. It didn't go away on more than adequate treatment for episcleritis and ocular surface disease. And as the patient's selfie photos show, there's clearly involvement of the sclera. There's actually almost nodular changes, and the remodeling of the vasculature there on the episclera tells you that this has been going on for a long time, and it's part of scleritis rather than episcleritis. And I think that's that they're the key sort of things. The clinical history, as Mr. Watson, taught us all when we were fellows, is the clue that makes you, clues you into the diagnosis. And probably she's had one ongoing low-grade attack for most of the 2 years. And it's just never really been brought sufficiently under control. And once she started systemic therapy, it really came rapidly under control. And I guess the other message really is the ANCA serology being positive, and it's important that we know how to interpret that. So do you want to talk a little bit about that, Alex, or do you want me to talk about this?
I'm happy to commence the discussion, if that's okay. Essentially, initially in the early testing phase, there was a two-step testing methodology with a screening, if you will, with indirect immunofluorescence, which usually would, on ethanols, fixed neutrophils, which would usually identify 3 patterns of staining, whether they were perinuclear, as seen in figure B at the top, or cytoplasmic, seen in figure A, or atypical, where there's granular staining throughout the neutrophil. Then these tests are usually typically confirmed with, if positive, with antigen-specific immunoassays, which are performed in a variety of ways. There's the myeloperoxidase usually goes with the perinuclear staining pattern, and cytoplasmic with PR3. And I think when used in combination, which they and sequentially, they have a very high sensitivity, up 98, 99%, which makes them have a good negative predictive value for ruling diseases out. They do have cross-reactivity, and so I just was wondering, Professor, if you had any experience with whether, how you're seeing sort of more contemporary testing heading with ANCA.
Yeah, so look, I think the big thing that's changed was when you used to do the screening immunofluorescence test, if the patient had a positive ANA, it was not, they would always have a positive ANCA as well, and it was really not possible to sort them out. But laboratories more and more are skipping the sort of screening assay, and now will just go directly to the antigen-specific immunoassays, which, as Alex said, there's a variety of ways you can do it, but they're all very sensitive and very specific. And increasingly, I think that's the way that testing is going to go, and we will sort of slowly withdraw from doing these indirect immunofluorescence screens. But it's still very common, so it's important if you're in your part of the world, if that's the way they do it, that you know that if the patient's ANA positive, the ANCA screen will always be positive, and it's really uninterpretable. And so that's probably the most important sort of general take-home message.
Thank you. And I think just as a final point, just talking about, you know, when we're talking about systemic diseases involved with scleritis, there's obviously a rheumatic sort of connective tissue disorder and vasculitis comprising 2 large groups of disease. And I think that it's just important to note that that there's a wide range of overlap between the different caliber of vessels which are affected, although the ANCA-associated vessels can be small to medium predominantly, as opposed to sort of other maybe immune complex mediated diseases which typically affect the capillaries. Did you have any further comments on that as well, Professor?
Yeah, thanks. So I think, just as you said, that sort of these are small vessel vasculitides. You can get involvement of larger vessels, particularly in the ANCA-associated vasculitides. So that's how you get involvement of the kidneys and the lungs. But because some of the larger vessels there can be involved, but it's really sort of an immune complex. Combination of an immune complex and a granulomatous inflammation that targets capillaries and venules, and that's why obviously it fits nicely into the sclera. Because the other thing about the scleral vascular physiology is that there are often areas in each quadrant where there's very low flow or even vascular stasis. And that then allows antibodies and immune complexes to precipitate out, to marginate out onto the vessel walls, and for cells to gather there. And that's why it's thought that this episcleral vasculature becomes involved in these vasculitides. So yeah, I think that's probably about our time that's up. And you know, I know if there are any more questions on the Q&A, I'm happy to answer those, but we'll hand back over to Rima and Alejandra. Thank you.
Thank you very much. We saw how the sclera can show systemic infectious and non-infectious diseases. and can result from an infection secondary to a chirurgical procedure, for example. Although it is not a common pathology, knowing how to diagnose and how to treat is very important. It can even save not only the eye, but the patient's life. So thank you, and we have a pretty hectic Q&A session. So
Yeah, I'm getting there. I've still got a few to go.
okay.
May I
I
start
hope
with
I've got
one
I hope I've got a credit average at least on my answers.
Okay.
So
So
I have a question for the case one. I mean, when we start, let's start the discussion. Did you consider taking out the explant?
Yeah, we considered it, but it was only the first month after the surgery, so we couldn't dare that because there was already still the subretinal fluid. We want to keep it as much as possible. If it was after, let's say, 6 months, if we have seen it lately, we would not hesitate to go and take it out. But that early in the time course, we were afraid of recurrence of the retinal detachment and performing another surgery about the detachment. Therefore, I wanted to keep it at first and see how the patient will respond to the antibiotic treatment, and he responded well, and we followed him for the first year. But then after the pandemic happened and he couldn't come from the other city, which was 5 hours away from Ankara.
Okay.
But
So
I think he's still good. No news, good news.
follow-up
He
was
didn't
good.
appear again.
So, Peter mentioned subconjunctival triamcinolone, 0.05 milligrams, right? ml, 0.05 ml. So do you consider subconj antibiotics also? Suppose you want to inject vancomycin or some of the
Yeah,
cases.
definitely.
Cases?
Yeah. I think you've got to use everything you can for those bad infectious scleritises. So we debride them, lay them open, give them subconj antibiotics, and give them high dose intravenous antibiotics as well. So everything that you can get there, because the blood supply is so poor, you've really got to try and get as much antimicrobial drug into the tissues.
Yeah, we could do it, but with the first 1 day of vancomycin, the patient started to subside, the nodular appearance decreased, and we give frequent topical vancomycin drops as well, every hour, nearly the first day, and then decrease the dose. But again, we could give subconjunctival as well. That's right.
We still have a few questions in the QA. For immunomodulator therapy in infectious necrotizing scleritis, can you please share your experience among the panel?
Yeah. Sorry. I'll stop talking. My apologies.
If I may, I think there are few unanswered questions. Thank you, Peter. Thank you, Sybil. And thank you, Alexander, for your beautiful cases and presentations. So while, the questions are being answered, I think Peter is typing the answers. I have few general things for all of you. Peter, you see a patient of scleritis. It apparently looks infectious to you. For example, Hind is typing, there is a pus point there. Now she is going to test it for infection. Would you still investigate for non-infectious causes along with the infection, or would you straight away do culture, smear, PCR, and not look for ENCAs and other things? I'll come to each one of you one by one.
Okay.
We can start with Sybil while Peter is
okay.
thinking.
Well, first I will go with culture and swab and start IV antibiotic therapy, and also I will investigate whether this patient has an underlying disease or not, an autoimmune disease or immune suppression. From the past medical history, our case didn't have such a thing, but mostly it is, we may see it in females after 60 years of age. We will look for other immune suppressive or autoimmune diseases. For example, maybe I can also ask you a case about intravitreal anti-VEGF therapy. For retinal vein occlusion, we are giving a patient intravitreal antibiotic therapy, intravitreal anti-VEGFs, which we commonly perform nearly many cases a week, all of us, for infectious, for age-related macular degeneration, diabetic macular edema, or retinal vein occlusions. This case is with retinal vein occlusion, and he developed scleritis. And he had rheumatoid arthritis, non-rheumatoid arthritis. Now we investigate him again with the rheumatology department. He doesn't have any symptoms in the body at all. And they have given him rituximab lastly. But he still has macular edema and he still presents with scleritis, even after we drop corticosteroids. So how will we proceed with this case? This is also a problem. So we have to look for autoimmune diseases, rheumatologic diseases, also in cases with infectious scleritis.
Thank you. So this is point number one, that even if the patient has developed infectious uveitis, you got to look for underlying cause. Now I come to the second controversial question, and Peter, this one is for you. In the era of biologics, if you have the resources and the availability to start any drug of your choice, would you still start with the conventional DMRDs, immunosuppressive, as the first line and move on to rituximab or anti-TNF as second line, or would you give rituximab, for example, as first line of therapy?
Yeah. Look, I think rituximab is such good treatment for scleritis. I'm more and more tempted to go straight to rituximab. We are a little restricted in our access, so that we would normally start a conventional drug, and if there were either side effects or a suboptimal response, go to rituximab. But I think if we have that conversation, 3 years from now, I suspect we'll just go steroids, rituximab, because it just makes such good sense with the pathophysiology of the disease.
And Alexander, do you still use cyclophosphamide? Because we knew like IV cyclophosphamide used to work very well, but all of us stopped using it because of the side effects or because of the biologics. Is there any role of cyclophosphamide still for you? Alejandra?
For me or for Alexander Newman?
I asked Alexander, but I think he's...
Alexander
Oh,
Newman.
no. Thank you very much for the question. Unfortunately, IV cyclophosphamide is a little bit before my time, and I must admit I've had no experience with it over the past 9 years. To be honest, the most common thing that I would have, where the most common area I would have heard it discussed with would have been the ANCA-associated vasculitides, most commonly GPA. But even then, as Professor McCluskey has said, even in Queensland, where I was before Sydney, we would routinely move straight to rituximab. And so I've never seen it actually used.
Thank you. And this one is for Alejandra and Rima. Pediatric scleritis, what would be special consideration compared to the adults?
It is really, really unusual. Pediatric scleritis. Actually, I have never seen one of the cases, but I perform national study with registers of the all the patients in Colombian registry, and there are some patients, pediatric patients with scleritis, but it's pretty rare.
Rima,
I don't
have you seen?
recall, no, I don't recall seeing any patient of pediatric.
So we don't see pediatric. And Rima, while you are at it, what would be the precautions? Because Peter spoke beautifully about scleral biopsy and when it should be done. So I'm sure many of our attendees would like to do biopsy in some of the patients. Can you tell us once again the precautions and how to handle the sample while the sample reaches the lab?
I think I'll be more comfortable talking about how the sample reaches, but how you procure the sample is a bit of challenge because these eyes are very inflamed, and whatever cases I have tried to do biopsy, they bleed a lot. So the whole problem is there is already an infection in the eye, and when you fiddle with it, the bleeding makes it even worse. So one has to be very, very careful while planning a biopsy. If you're very confident and you have a very well-defined area where you think you can get some tissue or maybe a pus or a discharge, if you're not confident, I think just a good conjunctival smear scraping should work. And another thing is, because it bleeds a lot, shouldn't be going overboard. If you're not able to get the tissue, should stop, because you don't want to create a thin sclera there and then add up to the complications. So it shouldn't be a very heroic action. If you're able to get it, fine. Otherwise, we can just scrape it. When we open the conjunctiva, we can just scrape it with a clean bud and send it for smear and culture. And how to transport it, we have a slide with us. We make the smear there then itself and send the bud for the culture. And as soon as, in the cold box, and better to inoculate at the same time, rather than having a gap in between inoculation and sample collection.
Peter, would you like to add any tips on scleral biopsy?
No, I think I agree completely with Rima. It's really difficult. The conjunctiva is often extremely friable, and you can sort of really get lost because of the bleeding, making it hard to know where you are, in terms of your dissection. So I tend to do exactly what Rima does. If there's a pus point or an obvious fluctuating area, I will try and take some samples from there. If it's not so bad, if you think you feasibly, technically can get a biopsy, it's good to get a biopsy from the sort of, shall we say, growing edge of the lesion rather than just taking pus, which will just be necrotic tissue. So if you can, I think that's a good place to get tissue. Often, if you just get some episcleral tissue, that will give you enough of a sample to be able to get the answer, because they're usually teeming with bugs, and where they're usually sort of, shall we say, fairly obvious bugs like Pseudomonas or a fungus that's got lots of hyphae. So they're not very commonly unusual organisms. I think that's all I would add.
No, that's very important. Yeah. So, Alexander, do you treat your patients of scleritis with subconj injections as suggested?
Might defer that to Professor McCluskey.
Sure.
So, Peter, my question
Yeah.
to you are, like, we have a lot of people, lot of attendees from Africa and other
Yeah.
countries where infection
Yeah.
would be common. Now, suppose in
Absolutely.
there are two issues in some of those countries which I understand. First, the testing, the lab diagnosis, to be very sure that it is infection, it may not be that easy. And second is the availability of all the antibiotics and DMRD, which means that they would prefer a local therapy in a situation where they are not 100% sure that it is infection or non-infection. Now, my question to you is, if you are in doubt, could you still inject or would you avoid?
Yeah. If there's any doubt, I certainly would avoid it. The problem with giving local steroids is that you can't reverse what you've done. And that's, so I think if you're not sure or you can't be sure that it couldn't be infective, you're much better if you want to use anti-inflammatory therapy to use oral steroids so you can stop them if things get worse. We would not use injectable steroids near the eye. I think it's a very important thing. The other, of course, important disease is TB. You know, I remember naively talking at a uveitis meeting in Thailand and talking about subconjunctival steroids, and a very nice Thai ophthalmologist put up her hand and said, "Did I know that 40% of scleritis in Thailand was due to TB?" Which I didn't at that time. So you've really got to be very, very careful. It's very selected cases where you can use, you know, subconjunctival steroids.
So I think it's a very important point that subconjunct steroid, once you are sure you are dealing with non-infectious entity. If you are in doubt, don't inject locally. Yeah. Sybil, this is the last question I think I'm asking from you, and it is from Hindamin, who says she has a patient who has 2 foci of purulent scleral nodules. Do you think it's enough to take the swab and send for culture, or does she need biopsy as well?
And Rima has already explained this. First of all, we'll make the swab and culture. And if we cannot get any result from those, then I will go to scleral biopsy. But before that, I will wait for the results of the swab and culture.
So, Peter, now is the last question for you and for all of you. One-liner, one carry-home message from today's webinar. So, each one of you, please give one-liner. Take home
I'll
message.
start. I'll start
Yes.
and say the most important thing is the history and the examination, the clinical assessment.
Sybil?
Differentiation between infectious and non-infectious, as much as we can.
Alexander?
Just maintain a keen clinical suspicion when the clinical picture doesn't add up.
Rima?
Differentiation between scleritis and episcleritis.
Alejandra?
From treatment and also the differentiation between infections and non-infectious. And the important message here is that we can even save the eye and the patient's life if we act promptly.
I think the most important thing towards the end of this still remains the clinical acumen. So for all the attendees, you may see very fancy investigations, anterior segmentosity, scleral thickness, MRIs, God knows what all. But as you heard from each one of the panelists and expert, it's all about clinically differentiating between infection, non-infection, differentiating scleritis from episcleritis. So I think that makes a lot of difference. We saw beautiful cases. Thank you so much, our younger members presenting those lovely cases. And I think it was all about the clinical. And again, very important to look for the change. But it's not that you call a scleritis which remains scleritis forever. Within that broad head of scleritis, you may have new symptoms, new signs, new findings developing. So examine patient every visit as if it's a new patient. Don't carry forward what has happened unless you actually want to compare and look at it. And you may realize non-infection turning into infectious over a period of time, and there is no harm in changing the diagnosis or your thought process or the treatment. That's how uveitis is, and scleritis is one of the most difficult forms of uveitis we have. With this, on behalf of IUSG, I would like to thank you all for your time, your efforts, all the experts, all the presenters, and of course, all the attendees. And we will see you all next 8th of June on very important topic of toxoplasmosis. Please fill up your CME credit hours. You will receive an email. Please fill up the form and you will get CME credit hours for this one. Thank you very much, everyone, once again. Truly appreciate.
Thank you.
Right. Our pleasure.
Bye.
Thank you.
Bye.
Bye.
Thank you.
Thank you.
Peter, there is a question which you may have to answer from Anna. Differentiating posterior nodule from chorioretinitis. Peter is gone already. Okay. One of you will have to do.
Okay. Thank you.
Bye.